Um, all right, so let's start. Good evening. It's 7:01 Eastern Time. Welcome you all. We have a very, very special session tonight, not because it's the day after election, but because we have our endocrine section. And today's session is all run by women in endocrine surgery and AHNS. I'm very proud of this session just to show the depth and breadth of expertise that women bring to head and neck surgery, to endocrine surgery. Very pleased to introduce our panel, and after that, I'll be in the background and run entirely by our moderators, Dr. Lisa Orloff and Catherine Sinclair. We are very fortunate to have Dr. Amy Chen, Dr. Maisie Shindo, and Dr. Tanya Fancy, and Dr. Julia Noel and Dr. Erin Buchek. All right, Lisa and Catherine, please take it away.
Yeah, I'll just start by adding Dr. Beth Cottrell as our other discussant tonight. So
absolutely.
So yes, we have three. Yeah. So when we were invited to do this, I was hoping that we were all going to be celebrating the first female vice president of the United States, but it sounds like we're a little too early to say how that's going to turn out. So it's still wonderful to be part of this all female cast of endocrine head and neck surgeons, and together with Catherine, we'd like to introduce. I'll introduce the first panelist, and maybe Catherine, you and I can alternate thereafter. But we have three cases prepared tonight for interesting discussion, and Tanya Fancy is going to present the first case of a relevant endocrine topic in thyroid surgery. So Tanya, why don't you take it away?
Sounds good. So we're going to present from workup of a nodule all the way to recurrent disease. Today's focusing on well-differentiated thyroid cancer. I'm going to go ahead and share my screen. Maybe. Give me a second, I'm not able to.
There we go.
Okay, let's go. All right, so this is a 55-year-old gentleman who presented with a complaint of a goiter. He discovered he had that from a recent ultrasound at a health fair. Generally asymptomatic, didn't know that he had it until he had that ultrasound. He has a past family history that's significant for a mother that had papillary thyroid cancer, and then personally no history of thyroid disease. Prior history of a right carotid endarterectomy and no other relevant surgical history. On physical exam, nodularity bilaterally of the thyroid doesn't seem significantly enlarged, and on flexible laryngoscopy, vocal cords are mobile, symmetric. This is the ultrasound report that he brings with him that basically says no evidence of significant carotid stenosis, and then incidentally they note a 2-centimeter right thyroid nodule, and of course they recommended that he have that investigated further. All right, anything, I guess I'll just, so next steps for him, of course he had blood work done, his T4 and TSH were within normal limits. And then, you know, went on to go ahead to get an ultrasound because this ultrasound that he got was obviously a screening ultrasound. So he had an ultrasound done by one of the head and neck ultrasonologists. And that's the report that we have. And so it's basically a right mid-lobe nodule that measures about 2.9 centimeters in maximal dimension. And then on the left also what they're calling a dominant nodule that's 1.9 centimeters also in maximal dimension. And then numerous bilateral scattered nodules that were sub-centimeter, clinical follow-up being suggested there. So this is the picture of that nodule and just different views of it on that right side.
Tanya, can we get maybe the panelists just to comment on these ultrasound images?
Yes, please, that'd be great.
Just talk a little bit about what they look for in an ultrasound of a thyroid nodule in terms of determining biopsy criteria and risk of malignancy. Dr. Chen, Dr. Shindo, Dr. Cottrell, do you want to chime in here?
Sure. So we're, going to be looking for things like solid versus cystic, if there is a cystic portion, just how much of it is cystic, the echogenicity of the nodule as well, whether it's isoechoic, hypoechoic, et cetera. And then obviously looking at the margins of the nodule, making sure that there aren't any areas where we feel like there is extra capsular invasion or extension, for example, into the strap muscles or posteriorly, for example. Obviously, a still image is not nearly as good as the actual active image when you're doing the ultrasound yourself. But you can certainly see a lot of things from sort of the key images. We all do look at the vascular pattern. I don't think that really has as much bearing these days. They've kind of changed criteria in terms of that used to be something that was included, but sort of has not been included so much in more recent years. So.
Thank you. And is there anything about this nodule that looks particularly concerning, or does it look fairly innocuous in the images we have?
I would say that size.
Tanya, can you stop sharing, because I wanted to share a picture.
Yep.
Thanks. It's not a big deal, but I think it's. So I wanted to show this picture. I think many of us have seen this diagram in our ATA guidelines, and if we were to look at the borders, the echogenicity, and the size, this is how, particularly for the learners on the call, how we determine what is benign versus high suspicion nodules. So this is taken from the American Thyroid Association guidelines 2016 version. So that's all. I'll
Great.
stop sharing.
Tanya, do you want to keep going?
Yeah. Okay, so this is, that's the nodule on the right side. And then, sorry, this is the one on the left, a little bit smaller. So this is, I just pulled this up to have on there as well. You know, there's this grading system based from the American College of Radiology as well that a lot of us use. A lot of radiologists, most of them in fact, are now including this at the end of their ultrasound reports. It kind of gives us an idea of how much to worry about a nodule, how suspicious it looks based on different criteria, as you had mentioned. And then they also some guidelines about size, and depending on what their TR level is, what the next step in management needs to be. So also a nice referral there. So patient went ahead with image-guided FNA of both nodules, the larger nodule on the right as well as the one on the left. And the nodule on the right side came back with atypia of undetermined significance, showing few groups of follicular cells with cytologic atypia. And then reflex Afirma testing was sent out, and that was the result that we got there.
So maybe do the panelists want to talk a little bit about Afirma test? I mean, there's obviously two main companies, you know, that there's a couple of others as well, but Afirma and ThyroSeq being the two main ones. And can anyone give a brief overview maybe of just the differences, not in terms of percentages, but just differences in terms of what the tests look at?
So I can start. So the Bethesda class is the way that we talk about cytology reporting in a standardized way. Before the Bethesda classification was started, it was pretty much just haphazard. Oh, it looks funny, or it's benign, or it's malignant, but it was very difficult to understand the language of different cytopathologists. So they convened a conference in Bethesda, Maryland, back in the 2010s, and came up with these different classifications. So Bethesda class 3 and 4 are the indeterminate nodules, which are the ones, as I tell my patient, we don't know for sure whether it's benign or whether it's malignant. It's kind of in the middle with the gray, in the gray zone. And then there are additional tests that we can do to determine the risk stratification of whether it's more likely or less likely to be malignant. So essentially that's what we're doing with Afirma and also with ThyroSeq. Those are the two largest ones. I should say I have no disclosures. I don't work for either company or any company. But this just gives us an idea of whether it's more likely or less likely to be malignant. The things that are different between Afirma and ThyroSeq is pretty much the accuracy in terms of, for Afirma, when it says that, in this case, it says it's suspicious. It doesn't, this was done, they did do some, looks like they did look at BRAF, RET, but I don't see a HRAS or NRAS or any other sort of genetic signature for this. So it's difficult to know for sure when it's suspicious, whether it is a malignancy or whether it's a NIFT-P or whether it's just a adenoma. If it's benign, if the Afirma came back benign, then it's much more reassuring that it is benign. So it doesn't tell us a whole lot other than it could be a malignancy. That's all that we can really tell the patient.
Okay.
So can I add a couple of comments to all that? When it comes back AUS, the AUS can be a little bit different than FLUS. Both are categorized as Bethesda suite. I think that depending on how it appears on ultrasound, the AUS, I think malignancy risk can actually be potentially higher. The other thing to think about is when we get this kind of a diagnosis, I would typically ask for a lymph node mapping if it hasn't been done. So I think one important thing is that one should always look at the ultrasound images yourself, because depending upon where it's done, which radiology center you get this done, some of the places may not comment on the things that are very important in terms of decision making. So that's important. And then, a lot of reports will say no lymphadenopathy, but if you really look at the images and the cine suite that they submit, the lymph node mapping could be like just from here to here, and it's really inadequate. So I always look at the cines myself to make sure, number one, that it is adequate, because you could easily miss a level 4 node down here if you don't follow the cine suites. The other additional comment I would add to Dr. Chan's comments is in trying to decide what is your best molecular testing that you're going to perform in these nodules. I think that knowing the risk factors, so for example, if the patient has one family member with a PTC, papillary thyroid carcinoma, but if let's just say if he had other risk factors such as radiation, multiple malignancy syndrome such as PTEN mutation risk, multiple family members of breast, ovarian cancer, things like that, I would have a long discussion with him about whether or not he may just want to consider just removal instead of molecular testing. And I think that's important. Knowing which molecular testing tests you're going to use is also important between the molecular profiling versus the gene sequencing, classifier. I think that it's important to know the two classic double-blinded prospective studies that were done comparing these two different tests, the Afirma test versus the ThyroSeq test. And both now, the double-blinded studies are actually showing that the negative predictive value is quite good. And I would say that the ThyroSeq, and again, I don't have any conflict to disclose, but the ThyroSeq does provide a lot more information in terms of what specific mutation might the lesion contain. So I get a little more information with the ThyroSeq than with the Afirma. So those are just the things I wanted to add to that.
When you just you brought up sort of the familial thyroid cancer, how much weight do you place on there being one family member who has had a first-degree family member who's had thyroid cancer compared with 3 or more family members, which has sort of been the classic, I guess, confirmed sort of definition of familial thyroid cancer? Do you know how much extra weight would you put on it when it's just one?
Usually 3. Yeah, just like 3 or more. is when I start getting really concerned about familial papillary thyroid carcinoma syndrome.
Fantastic.
Maybe we could post those references that you did refer to, because I think the audience may be interested in reading up more on what we don't have time to go into in great detail today. But
yeah, it's actually in our endocrine curriculum in our department.
Yeah,
I can probably pull those. And what would you like for me to do with them? Send them to you.
You can email them to JJ. He could probably circulate it to fellows.
I could do that. Yeah, I can just extract those out of our curriculum box. Okay.
So thanks for those comments. And I think I'd like to just add one comment, which is to everybody, wherever they're practicing, it behooves us all to be sort of familiar with our own regional cytopathologist expertise, because the rate of calling something an indeterminate nodule, an AUS or an F+, is going to be quite dependent on the confidence level and the experience of the cytopathologist. And that in turn influences the statistics on the performance of these molecular tests. So
that's a good point.
Okay. Great comments. So Tanya, why don't we let you finish the case?
So that's a Bethesda system that was mentioned earlier, just for reference. And then management-wise, plan observation. I don't know that that's something that anyone would recommend at this point. In certain patients, of course, if they didn't want surgery for whatever reason or weren't candidates for it. But so I discussed a thyroid lobectomy for him. And that's what we went ahead with. He had a focus of carcinoma, papillary thyroid microcarcinoma, and that was obviously separate from the actual original lesion, which ended up being a follicular adenoma. That's a typo there. I'm sorry. It was 3.1 centimeters for the greatest dimension there. And that was the main nodule with an incidental focus of papillary thyroid carcinoma.
Did he have a contralateral thyroid nodule as well, or did I miss it?
He did. And that one, the FNA on that was benign. And I offered him the option. I said, if you don't want to worry about surveilling that, you do have an option of just removing the whole thyroid. Doesn't have to happen. He reported some hoarseness after his endarterectomy and didn't really want to have to deal with the possibility of having that happen again or even on the contralateral side. So he felt comfortable just surveilling the left side. So that's what he went with.
Was there evidence of autoimmune thyroiditis on the specimen?
No, there was not.
To that end,
would that influence you, Dr. Shindo, in terms of doing more surgery?
No. I was just trying to reconcile the cytology,
all right,
with because it was a very isoechoic nodule, and sometimes with autoimmune thyroiditis, you can often get AUS on the FNA, right? I mean, you get that right. The description was nuclear overlap, crowding, and that's when you can often get false positives when you have that kind of a picture. The thyroiditis is the one that gives you the false positive, and yet it's only a 1 millimeter, microcarcinoma. So clearly that was just incidental.
Yeah.
But
thank you.
Thank you, Tanya.
Thank you so much, Tanya. I'd like to introduce Dr. Julia Knoll from Stanford, who I think is going to present our next, where is she? Somewhere here. There she is. Hi.
Hello.
Great. Who's going to present our next case? Thank you.
Okay. Yes, let me share my screen. Okay. Okay. Everyone can see that okay?
Yep.
Yes.
Good. Okay. So this was a patient that I had a little bit earlier this year, and I know there's a bit of a spoiler alert with the incidental papillary thyroid carcinoma, but there are some interesting aspects to this case that will be worth discussing, I think. So this was a 64-year-old man. He had interestingly had a nasopharyngeal foreign body that required removal, and on the MRI done pre-op for that, an incidental right thyroid nodule was noted. He had a relatively unremarkable medical history, as well as lack of family or personal history of malignancy. He had no radiation exposure and really had no thyroid evaluation prior to this. So when I saw him in clinic, he had some intermittent globus sensation, but was otherwise asymptomatic. He did have a palpable right thyroid nodule, no notable lymph nodes on his exam, and a normal laryngoscopy. And then his labs are down at the bottom. They were all relatively unremarkable. And I'm happy to stop at any time if there are any discussion points or keep going.
Interested actually just to hear from the panelists regarding, the measurement of thyroglobulin procedure preoperatively. Does anyone do that? Does anyone use that? I mean, what's your feeling on that? My feeling is that, preoperatively, not as useful as a guide, although I have heard some people disagree with that, and I'm curious to hear what everyone else's thoughts are on that.
I generally don't get it. Not routinely, at least.
The only times that I've gotten it is if there is a tremendous burden of metastatic disease that is known prior to the total thyroidectomy, just to get an idea of what the level is. But I don't routinely get it pre-op.
Beth, any routine or no?
If the ATA guidelines does not even recommend that.
That's right.
I'll speak up that I do get thyroglobulin antibody before surgery. I don't get it as part of a workup of a nodule, but once I've made the decision to take the patient to surgery, especially if they have cancer, but sometimes it's actually useful because of these incidental findings of cancer that you might wish you had had a baseline antibody level and or know whether the thyroglobulin was proportionate to the size of the cancer. In other words, we know that there are some thyroid cancer patients who have positive disease even when they have undetectable thyroglobulin. And I think that this is opinion. I'm not saying this is evidence-based from the ATA guidelines in particular, but there is often value in correlating what the amount of thyroglobulin or thyroglobulin antibody is pre-op with the volume of disease that's only found out post-op. So that's my rationale.
So this was the MRI that he had come into clinic with. Excuse me, let me go back. Which showed a 25 millimeter nodule in the right lobe, and there was no abnormal cervical lymphadenopathy seen. And then he had also had thyroid and neck ultrasounds prior to seeing me, which showed this nodule in the right lobe. And I know we briefly went over Thyroid's criteria in the last presentation, but this was given an overall score of 5. And there were no nodules noted in the contralateral lobe or abnormal lymph nodes.
Interesting that the TIRADS 5, you see how the weight of certain criteria can really upgrade a nodule, such as the punctate echogenic foci listed there as 3. And I think that it is well recognized that that is the characteristic that is most overcalled on the TIRAD system, because it's often difficult to distinguish colloid type echoes from microcalcifications. And the default is to call them punctate echogenic foci and put the burden on the clinician to, deal with this higher level TIRADS scored lesion.
I agree completely with that. I've had a number of sort of colloid lesions come, complex nodules come in from outside, and I've actually now, when I get a TIRADS 5 coming from outside, I always repeat the ultrasound anyway, but I'm even more keen to repeat the ultrasound because often I find that they are overcalled. Sometimes not, but often they're overcalled. And actually some people don't even need biopsies. So it's quite significant actually.
Yeah.
I can't tell you how many spongiform nodules come in with the thyroid 4 that I just no need a biopsy. And which is why I, the grading system that Dr. Chen showed is my preference, because I think it really kind of looks at more of the details of microcalcification, et cetera, et cetera.
TIRADS is very convenient in distilling everything down to a single number. And we now talk in a language of, oh, this is a TIRADS 3 nodule, this is a TIRADS 5 nodule, which is doing a disservice, I think, to the story of the thyroid and its nodules. It really very much oversimplifies a lot of pathology or a lot of anatomy. But
well, it goes from primary care to radiology, who then makes the decision of biopsy and then the workup. I think that's what's happening with that.
It's very convenient, but yeah, maybe we'll talk a little bit more depending on where Dr. Noel is going with this one on on that issue.
I do have a cine loop just to share with you so you can see the entire thyroid. This was from his in-clinic ultrasound. Okay, and then he had come in with a biopsy that was interpreted as a FLUS by the outside pathologist and then re-reviewed internally, and ultimately had the same result with the comment that this could be a Hürthle cell neoplasm or nodular hyperplasia with Hürthle cell change. And so we talked about having a repeat biopsy with molecular testing, going to surgery, or to do interval ultrasound for surveillance. And ultimately, he was a very nervous person, and this was weighing on him heavily, and he just wanted to go ahead and have surgery.
I'm sorry to be kind of a pain, but I presume that a lymph node mapping was done once you got the FLUS diagnosis.
It was, and he had no abnormal cervical lymph nodes.
So we talked about testing thyroglobulin antibody earlier, but I noticed, Dr. Noel, that you did test TPO antibody as well. And can you or any of the panelists comment on, the discussants comment on Hürthle cells and TPO antibodies and other significance of positive TPO antibodies in terms of the perioperative discussion with the patient about what that might mean to their long-term thyroid health and their nodule diagnosis, the presence of TPO antibodies?
I think this goes to what I was saying in the earlier case about thyroiditis and about how it might, oftentimes patients will ask, oh, will I have to go on medication after having half of my thyroid removed or not? And I think having that information can help counsel the patient. But I think it's not something I regularly and routinely check, but if it is checked, then I think that it can be useful in guiding the patient, and also in terms of looking at what's going on in the background of this biopsy.
I think the other thing is if the TPO antibodies were positive, you have autoimmune thyroiditis, you can actually have a lot of Hürthle cell proliferation in your cytology. So kind of bear that in mind, because that's where it might be helpful.
Laura, can you mute your iPhone, please? Thanks. Thank you.
Okay, and so he ultimately had his right lobectomy, and the pathology showed that the dominant nodule was a follicular adenoma of oncocytic type. And interestingly, there were 4 foci of separate papillary microcarcinoma, classic type, including one with a focus of lymphovascular invasion. And the largest focus was 4 millimeters, and there was one Delphian lymph node removed, which was negative for carcinoma. And so I will go on to, I think the question is, should a completion be considered, and what factors go into that decision?
Might turn this over again to our panelists in terms of discussion regarding completion thyroidectomy, given the multifocal microcarcinomas noted on pathology incidentally. Who would like to start?
I'll go back to the pathology.
I can't remember, were there nodules on the other side?
There were no nodules on the other side.
Okay, all right. And the lymph node mapping was negative?
It was.
Okay. And he's nervous?
He's a nervous person, yes.
I think if he's a nervous person, I would, I think that he might choose a completion thyroidectomy. The only thing that makes me think, perhaps that's something that he would want to do is this lymphovascular invasion piece. It's not so much that there are 4 of them or that the largest focus is 0.4 centimeters. It's more that finding of lymphovascular invasion. That's the only worrisome thing that makes me a little uncomfortable with. But if he's willing to come in and be surveilled and make sure that everything is okay, then I would be okay with that. I'm not sure what I would do with thyroglobulin at this point. You checked it pre-op, it was 13. If now post-op it's 12, I'm not sure. I wouldn't know what to do with that information.
And with that lymphovascular invasion, if you were going back in, would you think about removing any of the central neck nodes, or given they're negative on ultrasound, would you kind of let that be and then use surveillance thyroglobulin, post-operative thyroglobulin to sort of survey for recurrence?
I don't think I would do a prophylactic central node dissection, but if there's something there that looks weird or abnormal, even though I didn't see it on ultrasound, I would take it out. And then I would use thyroglobulin at that point to monitor for recurrence.
We actually had a question from the audience regarding the use of thyroglobulin for monitoring following lobectomy, thyroid lobectomy, as opposed to total thyroidectomy. And there's been a few studies that have come out recently looking at that. Dr. Chen, Dr. Shindo, Dr. Cottrell, do you want to comment on the utility of thyroglobulin for monitoring after lobectomy?
Well, I think, one of the more classic studies was out of Sloan Kettering with Mike Tuttle, that you can follow the trend. And I think it's, especially in somebody who doesn't have thyroiditis, it's not unreasonable to follow the trend. But, you're dealing with microcarcinoma, and, it's not like you're dealing with a 3-centimeter papillary thyroid carcinoma that you would expect to produce thyroglobulin in the absence of, chronic thyroiditis. So I think this is a little bit tricky because you're dealing with a microcarcinoma, and how much, thyroglobulin do we expect elevation? So I think that for somebody like this, I would probably just present this at tumor board at our institution, review the pathology to make sure that whoever's reading this, really there's only a single focus of lymphovascular invasion. We typically use like 6 or more is when we become a little bit more concerned with the risk of metastases, and then we might then recommend completion thyroidectomy. I think just because he has 4 foci of microcarcinoma, I don't know that I'd push for the completion. I think if he was really nervous, I'd just talk to him about the pros and cons of it. I would tell him that you don't really need to have it done. You can monitor closely. I don't think your prognosis is going to change whether you do it now versus a new nodule develop in a year or 2 years, whenever that might be. And then just kind of let him choose, assuming that, and I mean, you don't have any parathyroid in your specimen and cord work. So, I mean, taking the other side out is low risk, but he will have to, the on thyroid replacement if we take the other half out. although I guess you can see where he's at in 6 weeks with his thyroid function. If he's already trending hypothyroidism, what's the, I mean, he's going to become hypothyroid, so probably okay. Yeah, I think these are, challenging, and you just kind of throw the pros and cons at the patient, and, some people just absolutely don't want to be on thyroid replacement. Some people are comfortable just monitoring. So.
Yeah, I think with him being a nervous person, maybe that means he's going to come in and actually do surveillance. That would be a nice thing to actually have a compliant patient. I do think that, yeah, with the TPO antibodies being positive, you kind of are looking at, well, it might not be this year, but it might be next year, and the year after, you're going to be hypothyroid at some point, likely. And I agree with you that you just have to offer him, what's the least bad in this situation to him. I think we have to honestly say, is there a good likelihood that there's micropapillary thyroid cancer on the other side? Yeah. But is that going to, as you were saying, is that actually going to change your prognosis? Nope. So kind of going through I feel like these are very long conversations sometimes. Mm-hmm. This is like the post-op 10-minute appointment slot, and you're like in there for 35 minutes, like, wait a second, this is supposed to be a lot shorter, but it is so nuanced.
I have a question for everybody. How many of y'all are using, not for microcarcinoma, but for, let's say, a follicular carcinoma, minimally invasive follicular carcinoma? I'm going to just use that as an example in deciding completion. How many of you are looking at like gene trails or molecular markers, mutations in the tumor that you go back on the block and decide based on the mutation that you find to recommend completion?
At our institution, we're sometimes getting BRAF testing, but that's really the only thing that they're testing on final histopath for us. So I don't really have like a routine molecular panel to be making those decisions off of anyway. I mean, unless obviously they had an atypical nodule, FLUS, AUS, and they got sort of reflexive molecular testing. But other than that, I'm not getting much in the way of histopath testing, molecular testing.
I agree. We are not.
We don't either.
Doing that at ours. I've wondered about it though, for these sort of decision making. If this was like a TERT BRAF, if this had TERT BRAF mutations, would that alter your clinical decision making regarding completion thyroidectomy? And so there's all of these unknown questions, I think, with
right.
molecular testing, and maybe it will become mainstream at some stage, but I think we're a way off probably from that.
Well, and you have to really wonder, at what rate would a TERT mutation show up in your practice to make it financially worth it? It would be an expensive thing to just test every single, So I think that there's that financial question there too. I mean, even at our institution, we're really questioning whether or not reflexive molecular testing for AUS and FLUS is truly worth it.
Yeah, I just wanted to add.
Doing it.
I just want to add one thing about the levothyroxine dosage or dosing after this patient's hemithyroidectomy. Would any of you all consider just starting him on some just for a suppressive dose?
No.
I usually wait to get their TSH, and if their TSH is kind of heading towards the upper normal, I would definitely consider it. But if their TSH is like 1 or 2, and I usually obviously refer them to the endocrinologist, but oftentimes it's getting towards, high 3s, 4s, low 4s, they'll make a suppressive dose, yeah.
I think there are a couple of issues with that. I mean, the TSH is appropriately going to rise within 6 weeks of a thyroid lobectomy. So it's important not to overreact to that and deem that patient hypothyroid, but to consider that an appropriate response to a loss of half the thyroid, and to look at free T4 as well and correlate it with patient symptoms, because sometimes the TSH on the next measurement thereafter will be back to normal. So that needs to be trended as well, rather than immediately jumping to putting somebody on and committing them to lifelong thyroid hormone when maybe they were just in the process of equilibrating. The other thing, just a sideline, is the thyroid globulin trending you were referring to. It's important to know that doing an ultrasound exam on a thyroid and then sending the patient to the lab for thyroid globulin testing, their thyroid globulin is going to be up. So if you really want to follow thyroid globulin trends, you should not do it right after palpating the neck or doing an ultrasound exam.
Noel, do you have any more slides, or if not, we may move on? No. That was fantastic.
Yeah.
Thank you.
That's all. I'll stop sharing.
Yeah, that was great. Thanks. And I think Erin Busek is going to give the third case presentation. So Erin, if you want to take over the screen share.
Yes, can you guys see that?
We can see you. No. We can't see your screen yet.
Uh-oh.
There we go.
How about now? Okay. There we go.
Perfect.
Okay. So this was a case of a gentleman, 72-year-old, past medical history of hypertension, hyperlipidemia, back pain, and a history of PTC in the past. He was initially diagnosed in the fall of 2018 with an incidentally found left thyroid nodule that was picked up on a carotid ultrasound. He had an FNA at that time that showed a Bethesda 5 classification. He was initially seen by an outside surgeon, and in October of 2018, he had a total thyroidectomy, left central neck dissection, and a left lateral neck dissection. I don't have any of the imaging from that point in time. All we have is just the report from the surgeon. His pathology from that surgery showed a PT2N1B 3.1 centimeter cancer with less than 1 millimeter margins, positive for angioinvasion, no ETE, no lymphovascular or no lymphatic invasion, excuse me. And he had 16 involved lymph nodes. The largest deposit was 4.1 centimeters. I did get a chance to review the op note from that surgery, and the main comment was on a lot of bulky lymph nodes in level 6 and the lateral neck. A pretty substantial burden of disease at that time. He was then referred to an outside endocrinologist who began following him. His immediate post-op TG was 12.8. At that time, he received 155 millicuries of RAI, and his post-therapy iodine scan at that time did show some focal increased activity in the thyroid bed. They continued to follow his thyroglobulin levels. It dropped to 5.6 later that spring following his surgery. He then had an ultrasound performed, which we don't have, that showed some hypoechoic areas in the left thyroid bed. The endocrinologist, I believe, just opted to continue to follow him. His TG levels slowly just continued to trend upward. And then in January of 2020, he underwent another iodine scan that was read as normal. That area that was previously seen on the left had resolved. He was again seen back by his endocrinologist in the May of this past year, and his thyroglobulin was 8.3. At that point in time, his endocrinologist reported he was pretty concerned about this just hovering TG levels. And so he opted to get a PET CT scan at that point in time, concerned that there was some possibly non-iodine avid disease. And that PET scan did show in the neck that there was left paratracheal lymph nodes with an SUV of 12.4, a supraclavicular lymph node on the right with an SUV of 8.6. And then in the chest, there were multiple subcentimeter lymph nodes in the suprahilar region, subcarinal and right hilar lymph nodes that were less definitive. I can't remember the SUV, but concerning for low volume metastasis. He underwent an FNA by his endocrinologist outside that did show PTC in that right supraclavicular node. At that point, his endocrinologist actually participates in our multidisciplinary thyroid cancer conference. And so he was discussed at UAB at that point in time. The question was, at that point, do we do another round of RAI versus a surgical evaluation? I urged him to let us take a look at him. And so he was referred to me for his workup. He overall was asymptomatic, doing very well, had no issues or symptoms. One of the big things I made sure we do, I didn't have it at the time of his initial evaluation, but like I said, I made sure we reviewed his prior op note. From that, I determined he genuinely did have a very thorough neck dissection, lateral neck dissection, and a true central neck dissection. On physical exam, wasn't really able to palpate any cervical lymph nodes, particularly that supraclavicular node. We did do a laryngoscopy in clinic that showed normal true vocal cord movement, no dysfunction there. Pre-op lab work, his PTH was 42.8, calcium was normal, and he had an appropriately suppressed TSH. So I opted to get a CT neck and chest with contrast to further evaluate exact location of these lymph nodes, particularly given their location on his PET scan. They were very low in the neck / upper mediastinum. And I have the images of the neck in a minute. The chest did show several pulmonary nodules, the greatest size being 7 millimeters, and they were concerning for Mets. And so I have some CT images to take a look at. This is a slice looking at the left paratracheal lymph node, or one of them that you can see there. This is a little bit lower down, second lymph node in the tracheoesophageal groove. And then this second slice, or third slice, excuse me, is looking at that small right supraclavicular lymph node. At that point, we discussed options, and he had, in my opinion, decent volume disease in the neck with some small volume disease in the chest. And I recommended that we go forward with revision surgery in the neck, in the central neck, and then a right lateral neck dissection. Surgery in the left central neck was fairly challenging. The nerve was identified low and stimulated well prior to dissection. The lymph nodes were very scarred to that nerve, but did separate fairly well. And so we were able to preserve it, and it did stimulate well both before and after dissection. Notably, I made a comment, we didn't directly identify the superior parathyroid gland. It's unclear if it was removed at the time of the original surgery. And then here was his final pathology. The right lateral neck dissection was relatively unremarkable, so I didn't make any comments about that. But he had 2 out of 2 lymph nodes positive in the left central neck, both with extranodal extension identified. And then the right lateral neck, he had 3 out of 15 lymph nodes. And at this time, he did well from his surgery. He's referred back to his endocrinologist for discussion for repeat TG, which I have not seen yet. His surgery was fairly recently, and discussion of another round of radioactive iodine.
Oh, congratulations. That's a tough dissection on that low paratracheal node. And you made a comment, Erin, about finding the nerve low, which I take to mean that you were trying to get below the level of prior dissection in order to be able to identify it, not where it was scarred, even though you did encounter scar by the node to the nerve.
Yes, that's exactly right. I think I made a joke during the surgery about some comment we made a few weeks ago about it's like a Star Trek joke, you want to go where no one's been before. And that is 110% what I was trying to do.
That's excellent. So it didn't eliminate the sticking of the node to the nerve, but that's terrific that you were able to preserve function. So
yeah.
It brings up an interesting issue of the extranodal, which we do tend to use a threshold of about 8 millimeters for a central compartment lymph node as being clinically relevant or at risk. And that really is for that reason of extranodal extension. But I think we've all seen cases, just like you described, where the nodes do somewhat tend to congregate along the nerve and can be adherent to the nerve even when they're less than 8 millimeters in diameter. And I don't recall what your size dimensions were on these nodes, but certainly you appear to have intervened and prevented this patient from a likely vocal fold paralysis due to disease. So it's always that, between a rock and a hard place. Is the intervention going to cause vocal fold paralysis, or is it going to prevent it? But you intervened at the right time.
Yeah, and his, the one lymph node there is definitely 12 millimeters, so it met criteria. I can't remember the size of the other one.
It almost seemed like maybe it was the other node that was probably the one that was stuck to the nerve, just given its location in more medial. Do the discussants have particular comments about the preoperative imaging, the use of PET-CT, the implications of FDG-avid nodes?
I think I don't use PET a whole lot in these situations. Obviously, this came to your clinic with the PET already done. But I think cross-sectional imaging gives us a lot of good information. And particularly in re-op cases, I think the CT scan is really, really essential. Some sort of cross-sectional imaging is really essential. We've talked a lot about ultrasound earlier this evening, but I think in this situation, I totally wholeheartedly agree that cross-sectional imaging, in particular CT with contrast, is the way I would go to assess this area. The other thing is that with disease on one side and then disease on the other side, I think there needs to be some thought into what you start out with first and what to do if, for example, you started out on the left side and let's say that the nerve did not stimulate when you were done. Would you have proceeded with the right neck dissection, or would you have staged that right neck dissection? Those are things I think that sometimes I have to think through and talk out loud with the patient and with the trainees in the room.
And in his case, his right central neck didn't have any known disease. So in my mind, the right lateral neck didn't put his, contralateral nerve at a little bit of risk, I guess, with the vagus, but not any substantial risk. But we did definitely talk about that and what to do with the central neck on the right side, and did not want to touch that with a 10-foot pole,
right?
Given there was no disease there. But yeah, I would not have been super comfortable doing anything on the opposite side of putting that other nerve at risk, even though it technically stimulated at the end. It was beaten up pretty bad.
And the iodine uptake scan, they did not light up brightly on that. Was that correct? That was why the PET-CT scan was ordered? Correct.
And so I saw someone in the chat ask a question about external beam. I think that is a reasonable question at this point in time. I'm going to probably touch base with his endocrinologist and see what the situation is. I think the lung mets maybe make it a bit more confusing, and to see what happens now. That uptake scan was I forget how many months ago, so we'll have to see what it shows.
The other thing about the uptake scan is that it's a much lower dose of radioactive iodine that's administered. So you don't know whether if you give them 100 or 150, whether it would uptake. Mm-hmm. So I think XRT has been shown not to be very effective in well-differentiated thyroid cancers.
Sure.
Yeah, I was going to say maybe this would be a good type of case to actually ask for some molecular testing, specifically ask for BRAF testing or that sort of thing, to see if there might be more directed therapy that could be used if there's nodal disease in the chest or metastatic disease elsewhere.
Exactly. I think this is the sort of case.
So a couple of questions I have. His original tumor was unilateral, solitary, left-sided, correct?
Correct.
And so in thinking about this case, it looks like he has had persistent disease based on his thyroglobulin level.
Mm-hmm.
Right.
And he's got contralateral metastasis, which probably tells me that this has been there and now the TG is rising. So this is progressive. And I think it's interesting because his iodine uptake scan initially was lit up, and as Dr. Chen said, well, maybe, you know, the scanning dose was not sensitive enough to pick up disease. But the fact that he's PET positive is really concerning to me, because many of those PET positive tumors will often have BRAF plus TERT mutation. And so I think radioactive iodine is probably going to be less like, there's definitely studies that show that there's an inverse relationship in iodine avidity, you know, versus PET avid tumors of papillary thyroid carcinoma type. So, you know, surgery, I think, is going to be probably the key thing in removal. So I totally agree with surgical removal. The other point I want to make is, usually when we, for the trainees, when we get somebody with recurrent disease, you know, as we review the pathology report, we always want to look at not only how many nodes are positive, but what was the nodal yield. There was a really nice paper out of Stanford that specifically looked at that issue. And if your nodal yield is less than 21 in the lateral neck, in terms of how many nodes you took out, there was a higher risk of recurrence. And central neck, I believe the nodal yield was like less than 6. And then the ratio of how many were positive to how many you took out also made a huge impact on recurrence rate. So if you have, like, say, more than 50% of nodes, so we don't really know what the nodal yield was on this original surgery, because it was 16 positive, but that they take out, you know, 60 lateral neck nodes, which sometimes will happen. But if they took out, like, you know, 25 and 16 were positive, and we don't know if those 16 were lateral or central neck. So the ratio and the absolute nodal yield makes it, you know, our information that we look at in terms of subsequent, you know, thinking about their risk of recurrence. So, and I think that definitely molecular testing is now indicated in this patient, because I think he may be looking at targeted chemotherapy, some kind of, you know, clinical trial or something for his distant disease, rather than potentially, I mean, I think he'll still have to be retreated with radioiodine to see if the stuff in the lungs and these dyno take up iodine, but I'm not as optimistic. And I think so a lot of these clinical trials require that you prove that they're not iodine avid. So he may still have to get a treatment before they can qualify for a clinical trial.
What was his pre-op TG?
It
Because I
was,
saw your labs, but I didn't see the TG in your slide.
I think you said it was like 8.3 or something. It was kind of hovering there.
yes, yeah.
But
it
that's
was,
the prep, right?
Stimulated, still, the stimulated thyroglobulin is still not that high for chest metastatic disease, which sort of attests to the PET-CT findings and does suggest, even though the metastases were small, that perhaps there's, you know, is dedifferentiation.
Yeah, stimulated TG was here, and then this is still suppressed.
That's what worries me.
And I think it would be good to know what his TG is now that you've removed the disease in the neck. You know, if it's still 8.0 or something like that, or is it now 0.3, or is it now 0.3? I think that will tell us a lot too.
You made, I think it was Maisie or something, one of you made an excellent point, though, about persistent disease versus recurrent disease. And it's likely that this node in the right level 4 region was actually there all along. Yep. And it was perhaps difficult to see on ultrasound because it was very low, and its attention was called to it because of the FDG avidity, but it was probably there. And it goes back to your original point, Maisie, on early on in this hour, about ultrasound lymph node mapping and scanning all the way down to the clavicles and even behind the clavicles along the transverse cervical vessel drainage, and not just, you know, perithyroidal. And so maybe this patient's prognosis is actually not as bad as it seems, and you eradicated the remaining disease in the central neck and then what was out in the right lateral neck. So we'll hope for the best for him.
Well, hopefully he doesn't have a BRAF plus TERT mutation.
Yeah, yeah.
I think he would, he would benefit from some kind of clinical trial.
Yeah.
So I just want to make one point about this ultrasound, just in general, not in particular to this case or any of the other cases. This is something that I think happened to me this week. I had a patient with a isolated PTC at the left side. She had an ultrasound done in radiology and came to me with that ultrasound. The ultrasound did not show any significant lateral cervical lymphadenopathy. But when I saw the patient, I scanned her and she definitely had supraclavicular fossa disease, really low in the neck. And if someone who just went by the report and said, no, you don't need a neck dissection, they would have totally missed this large clump of disease. And so I think it's really, really important. And even if you were really, compulsive and looked at the images yourself and everything, you're relying on someone else's capture of the images. And I think and the radiologist who's interpreting the studies also relying on the technologist capturing of images. So I think it's really, really important if for those of us who do endocrine surgery, it's really like, it's like another pair of eyes that I can't even imagine. And I didn't train with ultrasound during my residency or fellowship. It's something that I learned from Dr. Orloff and Dr. Shindo and many others. And it's really, really so important. And it's always amazing to me every time. I'm like, oh my God, wow, I just avoided this big problem that could have happened to my patient. But just because I was able to just quickly scan and know what to look for. So it's really, really important, I think.
For the fellows, the head and neck fellows, what I try to emphasize, and our residents actually too, is that look at the cines and make sure that they're high enough. And when you're looking at the cine, you should be able to see that jugular vein drain into the subclavian vein. And if the cine images don't, you don't see that on the cine images, it's an inadequate study. And so you've got to take that responsibility to look at, look in those areas. Now, some people argue, well, okay, then I might get cross-sectional imaging because I don't have my own ultrasound machine and I don't have a good radiology department. That's fair. That's totally
fine.
Fair. But I think you got to look at those locations, because papillary thyroid cancer or medullary, it's notorious for hiding in those right where the jug drains into the subclavian and the retrocarotid nodes. It's do you call those level 4 nodes or do you call those level 6, deep level 6 nodes? You have to look there. It's like, I tell, head and neck fellows, like, would you ever take somebody to the operating room without looking at a CT scan? Would you ever do that? No, we would never do that. And we should treat ultrasound the same way. You cannot just rely on a report. I don't know how else to emphasize that. If there's one take-home message from this tumor board, is that.
Maisie, that was a perfect setup for what Dr. Givey and others, Dr. Fancy, Dr. Sinclair, and I had, the chance to participate in the curriculum development for the fellows for this current academic year. And we're happy to see that the AHNS is endorsing the need for exposure to ultrasonography in all of our fellowships and having a certain minimum proficiency with ultrasonography, regardless of how much endocrine surgery you're going to perform, because lymph nodes are sites of metastasis from all head and neck cancers. And it really behooves us all to be familiar with the anatomy and do exactly as you just said, to look at the images ourselves, to optimally do the images ourselves. But even if we don't have that capability to look at the acquired images and determine whether they're sufficient or whether we need to get correlating cross-sectional imaging or another ultrasound exam. So thanks for that emphasis.
Great. All right. Well, thank you so much. This was an excellent session. I learned a lot, and thank you for all of you being here. It's 8:05 in the interest of time. I see Dr. Fowler from University Hospital in Cleveland has a question. Would you consider external beam radiation because there is no radioiodine uptake? Just in 2 seconds, if anybody of the attending would like to
We already
comment.
answered that. We already answered that.
Yeah, we did cover that.
Okay, very good. So thank you again. In 2 weeks, we're going to have our next session, which is non-melanoma skin cancer. We're going to have an amazing session with a lot of folks logging in. I wish you all a very good night, and I hope you don't stay up too late tonight for the results. It's all going to be the same tomorrow morning.
Everybody be safe.
All
Take
right.
care. Bye.
Take care.
Thank you, guys.